and speak on a topic which I later realized after accepting that I probably have spoken on the same talking the same venue 3-4 years back, I mean prior to Corona or after Corona. Anyway, this is on perioperative management of diabetes. I see a lot of our colleagues here. Most of you are physicians, practitioners. How many of you manage diabetes in inpatient setting? I am a professor in a medical college running a DM endocrinology course. Fortunately, having diabetes under endocrinology in our institute. So all the more I am directly involved in main job of our department is to manage most of the inpatients with diabetes. Thanks to my other medicine colleagues, they are also looking after. So I saw only 2-3 hands. It means most of you are in outpatient setting or inpatient load may be relatively less, I don't know. But anyway, it's worth recapitulating some of these concepts which we use in inpatient diabetes, which will be of use. Your relatives and others may be undergoing surgery or getting admitted for various medical reasons, etc. So it's worth knowing some concepts, just like Krishna sir was talking about how our food and other processing, etc. got evolved, and our concepts regarding many conditions are changing, and so is this topic. With the rampant increase epidemic proportions of diabetes, obviously the hospital statistics also reflect that almost 50 or even 2/3, this is directly from ADA 2025, this statistics one of these. So almost 2/3 of our patients in a hospital are having hyperglycemia. They may be non-diabetics already, or there is a very important condition which we should recognize is stress hyperglycemia, also should be equally given importance. So diabetic patients many times come with an acute problem. They may have underlying micro-macro problems which they may not have got evaluated. This is to be kept in mind because many times the cardiac issue is actually the major stumbling block in the overall outcome of the patient, not actually the glucose of 220 or 330 or 120, which we always discuss too much in this kind of things. So preoperative proper assessment, etc., and the post-operative care, which is equivalent to the routine inpatient non-surgical patient, is very vital. So why is glycemic control important in a surgical setting? The surgery colleagues I really wish we have had only in this 12 years of my being there in the institute, only twice we have had a CME or interdepartmental discussion with the surgeons. முதல்ல போன உடனே குளுக்கோஸ் சரியில்லை, அதனால புண்ணு ஆறல. Especially our plastic surgeons, and அது வரைக்கும் ப்ரீஆப்ரேட்டிவ் வரைக்கும் சர்ஜரிக்கு கிளியர் பண்ணி எப்படியாவது அந்த சர்ஜரி நாளைக்கே பண்ணணுங்கிறதுல they were very very pushy type. But once a post-op small problem occurs, the first fellow to get the blame is sugar 220 இருக்கு, அதனால தான் அப்படின்ட்டாங்கன்னா முடிஞ்சு போச்சு, அவ்வளோதான். அந்த மைண்டில் அதே ஃபிக்ஸ் ஆகிடும். Then you know how much of pacification and explanation. இப்போ நான் பேச போகிறதுலாம் பேஷண்ட் எப்படி சொல்ல போகிறது? Next 5 minutes you are going to listen to scientific evidence on whether it really matters or not. But the patient அந்த வார்த்தை ரொம்ப ஸ்ட்ரைக்கிங்காக இருக்குது, and that too from the primary surgeon who is dealing with the patient. இது கொஞ்சம் ஜாக்கிரதையாக இருக்கும். I think அந்த வார்த்தைகளில் சில வாட்டி இன்னும் கொஞ்சம் பெட்டராக இருக்கலாம். That I think we can use better language to communicate to our patient, or give a handout which will tell them why they are on insulin, why they should, etc. So this is science which we all understand. The surgery is one of the highest form of stress, pathological stress obviously, and which leads to multiple levels. It causes hyperglycemia, including insulin resistance, which due to the stress hormone, counter-regulatory hormones, inflammatory cytokines, and increase in glucocorticoids and other hormones, etc. So which we know, and this hyperglycemia has effect on multiple cellular levels, which the severity of hyperglycemia, lot of animal studies, in vitro studies are there for all this, to say that the mitochondrial injury, neutrophilic dysfunction, etc., can have an effect on the healing process itself. This is fairly understandable, but how much it is getting translated clinically is what we should know. So the anesthetic, this is called flickering effect. யாருக்காவது இது ஏதோ இங்கே ஏதோ லூஸ் கான்டாக்டா, சீசர் டிசார்டர் இருந்தால் precipitate ஆகிடும். Anyway, so the idea of what I was trying to say is some of the anesthetic agents may also play a role in this. I think anesthetists will know this, but obviously their choice is not based on hyperglycemia. You see here effect on glucose by etomitate, benzodiazepines, and volatile anesthetics are pretty high. They may cause, but that's going to be transient. We know that less than 24 hours. That's why intraoperatively also in some of the major cases, they monitor glucose and insulin infusion is also given depending on how bad is the glucose. So there are some very nice papers based on which most of the guidelines are made. One such thing is here, the clinical outcome of hyperglycemia in the perioperative period in non-cardiac surgery. Why this word I was specific is because prior to these kind of studies in 1980s and 90s itself, it is well known that in cardiac surgery, the sternal wound is directly proportional to uncontrolled diabetes. The prevention of osteomyelitis of the sternum is a very important thing. Very same type of surgery, same outcome can be studied. So it forms the prototype for how to study perioperative glucose control. However, other surgeries are all different, intra-enteral and other things are different. That's why this kind of study showed that a pooled analysis showing in JCM 2012 itself, intensive control in non-critical care settings may reduce the infection, but most of them, the quality is very heterogeneous. This word, every patient is already. Most of these evidences are based on heterogeneous, small scale, low quality kind of. Low quality means robust outcome, like mortality. Hard outcomes are not there. Subjective. இன்னைக்கு அதுவும் இன்சூரன்ஸ் வேறு வந்துருச்சு. யூ கேன் அட்மிட் அ பேஷண்ட் ஃபார் மெனி திங்ஸ். யூ மே டூ அ சர்ஜரி, யூ மே ப்ரோலாங் இட் ஃபார் 5 days. 3 நாள் இருந்தால் தான் எனக்கு இன்சூரன்ஸ் கவர்னா அவர் 3 நாள் வச்சுருப்பாங்க. ஸோ அவுட்கம் அவர் எதுவும் ஐசியூவில் 2 நாள் வச்சுருங்க, சாட்டர்டே சண்டே வருது நான் ஊருக்கு போகிறேன். இதெல்லாம் உங்களோட டேட்டாவில் என்டர் ஆச்சுன்னா என்ன ஆகும்னா ஐசியூ ஸ்டேயில் லென்த் மாதிரி காமிக்கும் அது. ஆல் தீஸ் ஆர், data is becoming more and more shaky the more we go deeper into what they report. So overall, as physicians involved in this area, we understand that the poorer outcome and even higher mortality due to multiple reasons. We are focusing only on the first thing, which is hypo and hyperglycemia is in our hands. Patients come with an HbA1c of 12 or 13 or even, maybe slightly higher, but long-term complications, they are not going to change everything overnight. In the matter of these 5 days, what are you going to do? So many institutions, they have their own guide. I think we should all, consensus should be there. You should be knowing what the other side, especially our anesthetic team, even in a big hospital, the team changes. Inniki clear ஆகும் surgery நாங்கள் பண்ணிக்கலாம், டிஸ்கஸ் பண்ணி வச்சுருப்போம். The team today who will go and see, the anesthesia team will change. Tomorrow morning, there will be a big confusion. The patient higher இருக்கே, glucose நேத்திக்கு பார்க்கல, whatever. These things we can, unless you talk one-to-one, we will not know. So the anesthesia people actually write on all this very well, more than our endocrine diabetes journals is what my personal feeling is. Because எங்கிட்ட ஒரு anesthesia அதான் நான் ரொம்ப ஆர்கியூ பண்ணப்போ அதான் சொன்னேன், நீ மாட்டுக்கு எழுதிட்டு போயிடுவே கிளியர்னு, நான் தானே நாங்கள் தேட்டரில் பார்க்குறேன். This is absolutely correct. I hope there are anesthetists here, nobody here. So they are absolutely correct. Many times we say, அந்த கைட்லைன் படி இது இப்படி இருக்குது. இல்லைப்பா அந்த பேஷண்ட்டுக்கு நாங்கள் தானே பார்க்குறோம், எங்களுக்கு தெரியும் என்ன ஆகும். டிஎஸ்ஹெச்சுக்கு மெயினாக அவங்க சொன்னாங்க எனக்கு, நாட் ஃபார் குளுக்கோஸ் ஆக்சுவலி. ஸோ அட் தி எண்ட் ஆஃப் த டே வி ஷுட் பி பேஷண்ட் சென்ட்ரிக், நோயிங் ஆல் தீஸ் இன் தி பேக்ரவுண்ட், மேனேஜ். ஸோ வெல் பிளான்ட் எலக்டிவ் சர்ஜரிஸ், பிளான் வெல் அஹெட் அட்லீஸ்ட் 2-3 weeks பிஃபோர், கவுன்சல் த பேஷண்ட். இது பண்ணினா நல்லாயிருக்கும், அதில் ஒன்றும் பிரச்சனை இல்லை. எமர்ஜென்சியில் தான் ப்ராப்ளம். ஸோ in addition to this, we know multiple reasons why a patient's glucose can go high. It's not only steroids. The patients kept NPO and stress, pain, the other medications used, leave alone the pre-existing factors of the patient. Already obese, long-standing diabetic. இப்போ இதில் புதுசாக இன்றைக்கி அது வேறு, அதுதான் ஒரு நியூ பாயிண்ட் டு பி ஆடட் ஃபார் திஸ் டாக் இஸ் தி GLP-1, tirzepatide and other drugs, semaglutide and all. How they are going to interfere, we will tell you. They are long-acting drugs, weekly once. இன்றைக்கி tirzepatide போட்டுட்டு 3 நாள் கழிச்சு ஆப்ரேஷன் பண்ணலாமா? We will come to it. I will come to it in a minute or two. So preoperative check, the more planned it is, the more you counsel, the more you take the surgeon and the anesthetic team into your, that as a team if you work well, it's very nice. Otherwise there will be some discrepancy here. It always looks like, glucose-நால தான் எனக்கு சர்ஜரி போஸ்ட்போன் ஆகுது, நான் என் பையன் ஊர்லேருந்து வந்திருக்கான், நான் நாளைக்கு ஆப்ரேஷன் வச்சுக்கலான்னு பார்த்தேன், இந்த வாரம் முடியாதுன்னு சொல்கிறீங்க. I am sure everybody will face this issue every day. So one of the, this slide is important, except in the extremes of glucose, like severe DKA or severe hypoglycemia or a honk, metabolic serious life-threatening complications, all the other cutoffs which every guideline will say, they are actually insufficient in their evidence. We keep, எங்கள் சுகர் எங்கள் அனஸ்தீசியில் சில வாட்டி ஒரு டீம் இருந்தால் 230 கேன்சல் ஆகும் கேஸ், இன்னொரு வாட்டி 300க்கு நாளைக்கு அவர் ஒரு விஐபியாக இருப்பார், தெரிஞ்சவராக இருப்பார், 330 கூட ஒரு டோஸ் இன்சுலினை போட்டுட்டு அடுத்த நாள் எடுக்கிறது பார்க்குறோம். இதெல்லாம் நம்மளே சயின்ஸ் விலைக்கு விற்ற மாதிரி இருக்குது. தட் சம்வேர் வி ஹவ் டு கம் டு சம்வேர் அட்லீஸ்ட் லாஜிக் ஷுட் பி தேர், அட்லீஸ்ட் சயின்டிஃபிக்கலி. ஐ ஆஸ்க் மை பிஜிஸ் எவ்ரிடே ஆன் ரவுண்ட்ஸ் வந்து இந்த பேஷண்ட்டுக்கு இப்படி எழுதுறோம், இந்த பேஷண்ட்டுக்கு இப்படி எழுதுனா ஏன் இது மாதிரி எழுதுறோம், வேர் ஆர் யூ டிரைவிங் திஸ் நம்பர்? எவ்வளோ சர்ச் பண்ணாலும் சில நம்பர்ஸ்லாம் ஷேக்கியாக இருக்குது. ஐ டெல் யூ, ஐம் கோயிங் டு ஷோ யூ சம் நம்பர்ஸ். 180, 210, 230, all these numbers are frankly speaking extrapolated from certain other less quality or low quality kind of studies. அதுதான் நம்ம தெரிஞ்சுக்கணும். அதுக்காக எல்லாத்தையும் டீலில் விடவும் முடியாது. That's where we have to know. So factors favoring good outcome, HbA1c less than 8.5. You see, we are not talking 7 here. This is because you can't achieve, this is not going to happen in 3 months or even 4 months. எவ்வளோ ஒசம்பி கொடுத்தாலும் ஆகாது. So self-managing patients, immediate post-operative period, short starvation period. So any small surgery, not kept NPO for a long, getting discharged very early, day care, all these patients will do very well. The more they quickly go back to their oral routine medicines, short insulin use, they will all do well. Complications will come in the other patients. In general, the safest, this is a punchline or a very important slide to be taken today, because at some point or the other, when in doubt, use insulin. Do not argue is my first humble request to our other colleagues regarding ஏன் நீங்கள் நிறுத்துறீங்க, அதிலே இருந்தான்னு. நான் இவ்வளோ நாள் நல்லா தான் இருந்தேன், மாத்திரை போட்டு நல்லா தான் இருந்தேன், இங்கே வந்து 2 நாளாக இன்சுலினுக்கு மாற்றிட்டீங்க, சுகர்லாம் ஏறி போச்சு. You have to tell them extra 2 minutes about this counter regulatory and stress and other things. Otherwise, why on insulin? We have multiple safety reasons for which they should be on insulin, including interaction with other drugs, predictable onset and offset, highly effective. The only side effect, if at all you want to call, is hypoglycemia. There is nowhere it is written it will cause renal failure, it will cause hepatic, it will interfere with the anesthetic agent, it will do this and that. ஒண்ணுமே கிடையாது. இதுக்கு மேல safe drug கிடையாது. And we have enough of varieties of insulin to suit to the needs of any of the patients. Kept NPO na nirthillam, short acting insulin. So do not hesitate to use insulin. Is a humble out of experience and some thought on this we are requesting. Then comes, these are all protocols given by medical journals as well as anesthesia journals. I have added few points here. Pump la irukanga ipo patient, CGM la irukanga. To be very frank, in our hospital, even though it's supposed to be corporate side also, we stop. The first thing is I will remove the pump, I will remove the CGM, because most of our sisters are not trained for all this. இனிமேல் உட்காந்து நாங்களே இப்போ தான் புதுசாக நிறையா கற்றுன்னு ஒழுங்காக பண்ணிட்டு இருக்கோம். அண்ட் there is no indication for all this. You go for educated length. ஏற்கனவே பம்பில் இருங்க. Except in type 1 diabetes, some pregnancy, 3-4 days of observation in the hospital we keep. But if she is going for cesarean or something, we stop. Because you put them on basal bolus and take them out. இதெல்லாம் வந்து you should know and talk very confidently and boldly to the team, saying that ஹாஸ்பிட்டலில் இது பிரச்சனை ஆகிடும், நீங்கள் இதை எடுத்து தான் ஆகணும், இல்லைன்னா இதில் கன்ஃபியூஷன் வரும். சப்குட்டேனியஸ், தட்ஸ் இன்டர்ஸ்டிஷியல் குளுக்கோஸ், திஸ் இஸ் blood glucose, capillary glucose versus blood glucose, all these are different. So use the best resources, what your sisters are trained, then only you will achieve the best. So most of the 2-3 important points is, I hope we all follow it. Any patient where he will go in for some dehydration, major stress, stop metformin at least 24 hours before surgery. இப்போ எல்லா காம்பினேஷனில் வருது, ட்ரிபிள் ட்ரக்லாம் வேறு இருக்குது. ஸோ ப்ளீஸ் ஸ்டாப் மெட்ஃபார்மின் ஃபார் த சிம்பிள் ரீசன் இட் மே காஸ் லாக்டிக் acidosis at the tissue level without your wanting it. Secondly, SGLT2 inhibitors. It is my friend in medicine department, Dr. Bhaskar, Emmanuel Bhaskar, he has done actually a epidemiological public-based study on UTI. Maximum usage by general practitioners in the periphery. The usage of SGLT2 in Tiruvallur and those periphery areas are so rampant. Any drug triple combination, it has come in generic now. Ideally, you should stop. Every month we see at least 2-3 patients of euglycemic decay. Unless you proactively manage, ஒரு மாதிரி S-dose இருக்கு, patient breathing சரியில்லை, ஆனால் glucose நல்லா தான் இருக்கு. This is how the standard definition la irupanga patient. You go, you have to hydrate them, give insulin, they'll become better in 2-3 days. Unnecessary stay. Stop பண்றதுல பிரச்சனை இல்லை, please stop பண்ணுங்க. Then that point which I wanted to convey for today, which is added to this list, is GLP-1 analog. Any patient on this long-acting GLP-1 analog ideally should be stopped 1 week before. Ideally. Emergency surgery இருந்தால் ஒன்றும் பண்ண முடியாது. முதல்ல நிறுத்திடுங்க, இன்சுலினுக்கு மாற்றுங்க. இதெல்லாம் சேஃப்டிக்காக. Because the anesthesists, there are not less than 10 papers, major guidelines coming from anesthesiologists on this issue itself. Aspiration due to GI motility problem. patient on long-term GLP-1 analog. Simple surgery, hernia, spinal போட்டிருப்பாங்க, aspiration ஆகுதெல்லாம் ஒம்பே வேணாம். Please stop. When in doubt, stop. எங்களுக்கு அந்த எமர்ஜென்சியில் இருக்கும்போது when in doubt you intubate அப்படிம்பாங்க. You are not sure of the airway, you intubate. அதே மாதிரி டயபெட்டாலஜியில் whenever you are in doubt, give insulin. Do not, ஏன் கொடுத்தா என்ன ஆகும், அந்த கேள்வியே வேண்டாம், இதுதான் safe. So some glycemic goals, ADA 2025, these are all the 3-4 major papers based on which they are quoting all this. Some of which are slightly old, but one Cochrane review in 2023, which is a pooling of 23 such studies, is the major basis on which even 2025 guidelines are based. So this is the summary of whatever I wanted to convey. Target around 140 to 180. அதுக்குன்னு 185 வந்தா இப்படிலாம் கிடையாது. You know, they are all mean values over a period of 3-4 days taken with capillary blood glucose. And you know, the lower you target, the more chance of hypoglycemia. If I have to say the other way around, actually prevent hypoglycemia first. That's the main aim of any inpatient. Second comes reasonable goal. Your resource will tell you, your HR department, how much of close monitoring you can do will tell you what you will do. Baseline cardiac, renal and autonomic, because that is where they will fall into. And இதெல்லாம் well known in inpatient. Avoid sliding scale. Basal bolus தான் பெஸ்ட்னு சொல்கிறோம். பட் நேற்று வரைக்கும் பேஷண்ட் வந்து 25-75 or 30-70 இன்சுலினில் இருந்திருப்பார். இன்றைக்கி ஆஸ்பத்திரி வந்த உடனே எல்லாத்தையும் நிறுத்துங்க. காஸ்ட் இஸ் ஆல்சோ a big issue. Please remember, based on a given patient's other things, you have to, this is individualized. Metformin, SGLT2, GLP-1, I have already mentioned. Please be ruthless in stopping it. This is my humble request. The patient can enter into any complication. We don't want this to contribute to it. And based on whether they're on NPH or regular or one of the analog insulins, you can play around with your insulin, give corrective doses and get back to this number as quickly as possible. In less than 200 vanditale, many of our other colleagues are happy. Is my general feeling. In the 230-300 கிட்ட ரெண்டு வேல்யூ இருந்தால் தான் they get worried about. So then comes post-operative diabetes. I'll quickly run through this because it is as equivalent to any other inpatient without any surgery also in a patient. So again the same thing, roughly around 80 to 120 சொல்கிறோம். ஆனால் இதெல்லாம் 80லாம் போச்சுன்னா in a cardiac patient you are entering into the danger zone of potential hypoglycemia and its complications. Repeating here, hypoglycemia should be prevented at any cost. And we have these old trials called RABBIT, which showed that basal bolus is superior to any other form of insulin regime. Then comes the pooled analysis of all the ICU and other inpatient-based hospital control. One of the first study was in 2001 in surgical ICU patients. Then came this nice sugar study, a multicentric ICU-based study. இதோட எல்லாத்தோட ஒரு essence is given in this slide. Is do not target less than 140 in most of your patients, or less than 120 லாம் வரணும்னு அவசியம் இல்லை. 140 to 180, maybe up to 210. Nice guideline says up to 210. So in the range போதும். In many of this is safety. You can go tighter in a given patient. Their endogenous insulin is good. They will. So multiple guidelines are agreeing to the same. Prevent hypo. Be reasonable. Do not be overzealous in treating. And this last one, again, the British anesthesiologist have, frankly, see, basically it's all planning. If you read these articles, how nicely they should have a team, the sisters should go and talk, why they are insulin, how they first time starting on insulin, they'll be on insulin for another 2 weeks till the healing and other metabolic things come out. இதெல்லாம் வந்து requires proper planning, involve the corresponding departments at the right time so that you get the proper input to the patient. I think many of our hospitals, I see many of our colleagues are always on phone getting 3 times CBG calls and giving orders over insulin. Simple things like giving insulin at the right place, right dose. Sistersக்குலாம் நிறைய வாட்டி அந்த டயலிங் பென்னெல்லாம் மாறிண்டே இருக்கு, ஒரு கம்பெனியும் ஒரு பென்னு. So lot of insulin technique errors are also there in this. அதெல்லாம் இங்கே எழுதலை, நம்ம சும்மா குளுக்கோஸ் டார்கெட்டுன்னு எழுதிடுறோம். Be careful with these things so that we do best thing to our patient in most of the time. So in summary, though I have given a reasonably, the evidence is less, but overall we understand that diabetes management is, when I say here it's not hyperglycemia alone, continuing the statin, the beta blocker and other things which they otherwise add, the cardiologist in a perioperative setting, most of those things matter. Even in hyperglycemia patients, it is the cardiac thing which will be of more risk than actually your 220 or 230 value. That has to be conveyed, at least for us, for our understanding. So the assessment of comorbidities is important. Anywhere between that 110 to 180, maximum 210 is a reasonable range for many of our patients, elderly type 2 diabetes patients. I have not touched much of type 1 for want of time. So a team approach and individualizing to that patient is most important in proper perioperative diabetes care. Thank you very much for your kind attention, and I'll be happy to.